Hello students. So in this presentation we're going to now talk about individuals that fall into the special population of diabetes. We will include type 1 and type 2, both types of diabetes, which is a metabolic disease. If you click on this link here, it is an active link to a video that explains the physiology of diabetes, the problems of why some people have diabetes, and the differences between type 1 diabetes and type 2 diabetes. And I did give you a funny meme here. Would you believe my blood sugar just tanked? So as an explanation for eating, the only thing here is that if you are truly diabetic and your blood sugar just dropped, which is what he means by tanked, which means you became hypoglycemic, eating chicken wouldn't raise it. And I'm pretty sure it's the same truth for dogs as well. So there is that. Okay, so we have a new case study. Hopefully now you're a little bit more familiar with how the case studies are going to work. Here we have someone with diabetes in this case. This is your case study for this one. Carrie, she's a 21-year-old client with type 1 diabetes, comes in for a personal training appointment. She tells you that she's been exercising routinely for a year, has achieved and maintained a healthy weight her entire life, and usually has a good control of blood glucose. She says that she checked her blood glucose level 15 minutes earlier and had a reading of 65 milligrams per DL. So you would have to understand all this facts here and what to do about this. First of all, what's with all the clients we're going to talk about, how do you proceed with this client? What would be your screening? What screening would you go through? And by the way, the information given would be the information that is relevant. So if I say here she's maintained a healthy weight, that means that she does not have obesity in this case. So you can assume that to be true. And I'm saying here that she's active, so you can assume that she's meeting the requirements for exercise as well. So you would have to think about, if she gives you this, talk about this level of blood sugar, is this a safe level to begin exercise? Would you continue on with exercise for this client? And then this, I would like you to explain to me what you would do from that, and explain what kinds of programming things you would consider with Carrie. What things would you watch out for? What kinds of things would you do as your programming guidelines for someone like Carrie? What would you have to keep in mind? What things would be something to be particularly interested in when it comes to her? Okay, so a little bit about the statistics about diabetes incidence. This is an infogram here that gives you a quick look. You can see that 29.1 million people have diabetes. That's a big chunk of the population. And the other side of it is about 86 million have pre-diabetes, which should be a positive risk factor based on the risk factors chart. So when you look at risk factors for cardiovascular disease, 86 million people would have pre-diabetes as a positive risk factor for our disease. So that's a big number. And it gives you some examples about the difference between type 1 and type 2 diabetes. So this is an infogram that highlights all the major points of diabetes. But some other numbers that you can go for other numbers would be the American Diabetes Association. This is an active link that will take you to American Diabetes Association, also known as the ATA. There's many organizations known as the ADA. And this website, if you go through it, has good information for individuals that were just diagnosed with diabetes, and they need to know a little bit more about what they have in store for them. It does talk about different ways of finding out about diabetes through different tests and what to do once you have it. So lots of information in the American Diabetes Association. So that's a good website to go to for more information, not just for you working with a new client with diabetes, but for them that are being diagnosed with either type 1 or type 2 diabetes. And the sum here, again, 90.3% of the American population, or 29.1 million Americans, have diabetes in the United States. It has increased about 7% since 2010, so the number keeps on. Well, we do have more larger population, larger aging population, so we have more folks, of course, that would have it. Type 1 is a little bit less frequent, about 1.25 million. Diabetes in general is the seventh leading cause of death in the United States for Americans. And diabetes, pre-diabetes is a risk factor for heart disease and diabetes as well. If you have diabetes, if you don't already have it, you're at a higher incidence for heart disease, especially, and this is true if it's not well controlled. Well controlled diabetes actually will keep your incidence for heart disease lower. So that's one other good reason to keep it well controlled. Okay, so diabetes mellitus or mellitus, however you like to say it, is a group of metabolic diseases characterized by excessively high blood sugar levels, blood glucose levels. Three different types. Primarily when we say diabetes, we're talking about either type 1 diabetes or type 2 diabetes. Women may sometimes get gestational diabetes during pregnancy, but it resolves itself after delivery. So we'll talk more about gestational diabetes when we talk about the special population of pregnancy. We'll do it then. So diagnosis of diabetes, different tests that can be done to detect whether or not there's diabetes. Diagnosis is either based on a fasting blood glucose test, two fasting glucose levels of 126 milligrams per DL or higher, in the OGTT test, which is, there's two tests, 2 hours after a meal, of 75 grams of glucose, and you get a high glucose measurements. And the more popular test now is a blood test known as the A1C, and it actually tests the average blood glucose levels for the past 2 to 3 months. And the good news about this one is that you don't have to fast. For folks with diabetes or pre-diabetes, is not very, for really all of us, I would say, fasting is not something that we look forward to. So the blood test is a lot more convenient, easier to implement, and again, it tells you what's been going on for a couple of months, so that's good. As far as the classification, this is from your textbook table 4.4. Normal should be, if you've been fasting, the fasting blood glucose, it should be less than 100. Certainly if you have not eaten, your blood sugar level should be low, so that's what we expect. Pre-diabetes, though, would still keep you at an elevated rate of 100 to 125, and you may remember those numbers from the risk factors for cardiovascular disease. Those were the defining criteria for a positive risk factor for pre-diabetes being one, and diabetes, if it's higher than 125 after you fasted, that's an indication that you have diabetes, and that's how diabetes is diagnosed. The 2 hours after test, 75 grams up to 75 grams of glucose, different numbers for that. So if we give you 75 grams of glucose and you're healthy, your body should be able to bring that sugar levels down to below 140. If you have pre-diabetes, it's still going to be high, between 140 to 199. And if you have diabetes, it will be 200 or higher, so higher than 199 milligrams per DL. So that's how it is diagnosed based on these tests. Regulation of blood glucose levels, a normal regulation of blood glucose levels, it should be that regardless of what you eat, through two different hormones, insulin and glucagon, you should be able to keep blood sugars levels within the happy window of 70 to 110 milligrams per DL, per deciliter. So someone who's healthy is able to do that. If you eat too much sugar, insulin, if you have blood sugar levels are too high, insulin comes in, is released, and insulin will lower it back down. If you have blood sugar levels are too low, glucagon should help to convert muscle glycogen or convert glycogen back into blood glucose, so then it can bring your blood sugar levels up and keep you at that happy place of homeostasis. It's really important. All right. So normal carbohydrate and glucose metabolism, just to refresh your memory if you've forgotten from previous classes. Glucose must continuously be circulated in the blood in order to serve as a fuel source for cells. Normal adult male in fasting state between meals, the blood glucose concentration anywhere from 70 to 110 milligrams per deciliter. So that's where it should be. Since blood glucose levels varies, you have hormones that are employed to control glucose levels. Remember, hormones are the communicators. They communicate with cells. So most significant hormones for blood glucose regulation are insulin and glucagon, but also epinephrine and cortisol. We use those, particularly true for exercise, to keep blood sugar levels high, or where they should be, I should say. Insulin lowers blood sugar, so it promotes the reduction in blood glucose levels when you have hyperglycemia, hyper meaning too much blood glucose, so blood sugar levels are high. Insulin is released to help you lower it and to promote it being moved into the cells. If it's exercising muscle, then we definitely want it in the working muscle. Glucagon, epinephrine, and cortisol work together to raise glucose levels to prevent low blood sugar, hypoglycemia, and it needs to work effectively to do that. Certainly very important for it to be very effective during exercise, when muscles are continually utilizing glucose and glycogen. So glucagon is a primary one. The liver converts glycogen to glucose in the liver and delivers it to the working target cells through the bloodstream. Epinephrine also helps to break down glycogen for glucose, and then cortisol also breaks down protein to convert it to glucose. After a workout, then you may see that cortisol levels may be elevated, and that's the reason for that. So blood glucose regulating hormones, let's talk about the main ones here. Endocrine tissue of the pancreas, the islet of Langerhans. You have the alpha and beta cells. The beta cells produce the insulin, and the alpha cells produce the glucagon. So one way I remember this, maybe this will work for you, or maybe it would not, but alpha, and there's an A in glucagon, there's no A in insulin, so alpha, glucagon, maybe that helps you to remember, maybe it doesn't. It works for me. So alpha cells produce glucagon, beta cells produce the insulin. Okay. Actions of insulin, role of insulin. So you can see in this diagram here all of the things that insulin is responsible for. So it stops gluconeogenesis, and these are words you should be familiar with from physiology, and certainly are terms that we need to understand fully. When you see genesis is the creation of something. When you see the lysis, lysis is the breakdown. So, and if you know the other terms, you can figure it out. So it stops the creation of new glycogen. Thus, gluconeogenesis stops the breakdown of glucogenolysis. It stops lipolysis, breakdown of lipids. It stops ketogenesis, the creation of ketones for energy, and also protein breakdown. It stops the breakdown of protein. So sometimes somebody goes like that aspect of insulin. It does get glucose in the go side, the green side. It promotes glucose uptake in muscle and adipose tissue. It promotes the breakdown of glycolysis, which is the breakdown of glucose. And the other side, you can see it stops the breakdown of glycogen, glucogenolysis. It stops the breakdown of glycogen. It's a go for glycogen synthesis, so the creation of glycogen, which again, that's how you stored glucose in the muscle and in the liver. It's a go for the protein synthesis. Again, the reason that perhaps some bodybuilders, which should not happen, are interested in insulin. And also the uptake of ions, especially potassium and phosphate. So that's some of the things that insulin is responsible for. But primarily, to remind you, and if you click on that, it will give you more explanation of insulin. It facilitates the movement of glucose into cells when blood levels are high, when blood glucose levels are high. It binds to receptors on the target cells to open the glucose gates, so it promotes the ability for the glucose to go into the cells so they can be utilized for energy, and promotes glycogenesis, which is the buildup of glycogen, especially when there's not a lot going on, when you're not doing any exercise. So let's look at the other side, and remember the human body likes these negative feedback systems to keep everything in a happy state of homeostasis. So let's look at glucagon on the other side. Glucagon is active when sugar blood levels are low. It does the opposite of what we talked about. It promotes glycogenolysis, gluconeogenesis, lipolysis, amino acid uptake, and ketone body formation. Again, if you click on glucagon, it'll give you a little bit more information. So they work together to keep, this is a picture of a liver, if you're wondering, this is a liver, to make sure the blood right here always has the healthy amount, or the good balance of sugar that it requires for optimal functioning. This negative feedback loop for insulin and glucagon, and I also added this into your modules so you can take a look at it. It should help you remember how they work together. In beta cells, right here you see beta cells release and so on. So this is again in the liver. So think about this. Normal blood glucose levels is 70 to 110, around that happy window in an adult. So what happens if you eat some bananas by themselves? So you eat some bananas. Stimulus causes an increase in blood glucose, so blood sugar levels go up. Beta cells in the pancreas detect the increase. Those beta cells then, because of they have sensors to detect that blood sugar increase, they release the insulin. Insulin then is going to stimulate the glucose uptake and oxidation in cells, the conversion of glucose into glycogen, and the synthesis of protein and fat. So we're going to create protein and fat. So, and then the blood sugar levels go back to normal. How about if something else happens? How about if we start doing some sprints? So blood sugar levels, that sense is a high intensity of exercise, high intensity short duration type of exercise in particular, are going to stimulate blood glucose levels to drop quickly. So then the alpha cells in the pancreas, was I saying liver? Is the pancreas. I have been saying liver, haven't I? Alpha cells in the pancreas detect decrease, right? And so that decrease leads to the release of glucagon. Then glucagon stimulates the breakdown of glycogen into glucose for release into the blood, gluconeogenesis, which is the conversion of non-carbohydrate sources into glucose, and then we get back to that normal blood glucose level of 70 to 110. So again, all of these, you have all these sensors. So you can see the alpha cells as the sensor for low blood sugar in the pancreas. So the alpha cells detect that low blood sugar and react by releasing glucagon, and then the beta cells in the pancreas detect that high blood sugar levels and release insulin to drop it back down. So hopefully that's clear. I apologize for having said liver. So here we go. Chronic uncontrolled diabetes is the problem. So individuals that have, and the key was uncontrolled. The goal for folks with diabetes is to keep it controlled through exercise and through medication, so we don't have the extremes, the too highs and too lows, which actually damages organs. As far as cardiovascular disease, it damages arterial walls that lead to cardiovascular disease. So the big complications, but it also is the leading cause of blindness, renal disease, lower extremity amputations because of the poor blood flow that can happen as a result of injured arterial system. So strokes are higher, eye disease like retinopathy and cataracts are higher. Certainly, as I said, heart disease and hypertension, peripheral vascular disease, neuropathy, which we'll talk a little bit more about later, which causes a lot of problems for doing exercise. And certainly you might have heard that for folks with diabetes, we really have to take care of the feet, because once you have an injury with diabetes, because of the irregular, or the differences in blood sugar, the more likely to get infections, and that's part of the reason that tissue could die, necrosis, which could lead to the increased risk for amputations. So type 1 diabetes. So let's look at type 1 diabetes first and see what that's about. So again, the beta cells destruction is the problem. It's an autoimmune process, so we're not really sure why it happens in some people and not others. More research is needed in that, but the beta cells, remember what the beta cells sense? They sense insulin, so pancreas not releasing any insulin, so they're insulin deficient, and they don't have the ability then to do what insulin does, which is to bring down the blood sugar levels. So this is why blood sugar levels keep on going up. About 5 to 10% of people have this type of diabetes, type 1. They usually used to be called juvenile diabetes, because it used to be used to have children. Now, because the other type 2 diabetes could also happen to children, it's no longer referred to as juvenile diabetes, but it's something that usually you're born with, and you detect it later on when there's lots of signs and symptoms. Usually the incidence is before the age of 25, so that's why it used to be associated with children. They have to be medicated, or they have to take exogenous insulin by injection or pump for survival, because the body cannot regulate those high levels of blood sugar. Insulin is injected in the muscle or in the lower abdomen. Usually when we're talking about exercise, you definitely want it not in the muscle, but you want it in the lower abdomen where it's more fatty. Rapid acting insulin reduces blood glucose in about 15 minutes, but and it lasts for several hours. So that's important to know. Depends on what they're taking. Shorter regular acting insulin reduces blood glucose in 30 minutes and continues for 3 to 6 hours. If you're working with someone with type 1 diabetes, you want to know this, because exercise is going to be affected by it. Intermediate acting insulin does not reduce blood glucose until 2 to 4 hours later, but it is effective for about up to 18 hours. And then the long acting insulin takes several hours to begin affecting blood glucose, and it keeps levels relatively even for about 24 hours. Uncontrolled or newly diagnosed individuals are the ones that are going to be more prone to ketoacidosis, which is a serious condition that can happen to people with type 1 diabetes. That can lead to a coma, and so it's a life-threatening event. Ketoacidosis can occur if blood glucose builds up, resulting in the use of, so you have a high level of blood glucose, so meaning that you have to think about, it's in the blood glucose is like in the blood, but it's not going into any cells, because there's no insulin to help it in, so all the doors and gates are locked, so you cannot, it's still going to stay high. And so because of that, the tissues, the working cells, don't have that glucose, although it's right there, they can't use it, so they have to rely on using something else. What's something else that's already there in cells? Well, protein and certainly fat is available. So those have to be used for energy source instead of carbohydrates. So there is some byproducts associated with that, because especially if protein is being used, but certainly if fat is being used. Symptoms include there's going to be dry mouth, nausea, salt water. It's going to be they're going to feel a little bit dehydrated, maybe abdominal pain, muscle weakness, shortness of breath, and mental confusion. So it can be very serious. Medications, type 1 diabetes, a little bit more on that. Here you can see an example of the pump and what it looks like. Now they make them in different styles and a lot more portable than they used to be. The dosage instructions are entered into the pump's small computer, and so the appropriate amount of insulin is then injected into the body in a calculated, controlled manner as needed. So insulin injected intramuscularly on the lower abdomen, inhaled, or via insulin pump, but not in pill form. So that's usually how it's used. The pumps now are pretty popular. Sometimes injected, but that's not as popular anymore. Rapid acting insulin reduces blood glucose in 15 minutes, but only lasts for several hours. Short acting, like I said earlier, it reduces in 30 minutes. Intermediate acting reduces blood glucose in 2 to 4 hours later, but is effective within 18 hours. Long acting insulin takes several hours to begin affecting blood glucose, and it keeps levels relatively even for 24 hours. So effects of exercise, type 1 diabetes, it reduces HbA. This is the blood test levels, indicative average blood glucose levels. So that's exercise helps with that. So it actually reduces your blood glucose levels. Improves body composition, which helps with to better regulate blood sugar as well. You see decreases in blood pressure and lipid levels. So much again, so less incidence of dyslipidemia, decreased mortality, meaning increased lifespan. Whenever I say decreased mortality, that's what that means. People are gonna expand the lifespan just a little bit. Can cause hypoglycemia during or after exercise or during subsequent sleep, so you have to be careful about your timing for exercise. Ideally, for those with diabetes, you want to exercise around the same time every day. Avoid late night exercise right before bed, because you may not be able to know if blood sugar levels have dropped, and there's nothing to do about it. Now there's different things you can use for that, and some folks that have type 1 diabetes will wake themselves up on purpose and check their blood sugar. There's now dogs that can be trained to detect changes in blood glucose in their owners, so they can wake them up as well, which is a more fun way to do it. So there's some options available for that, but certainly exercising late at night, or the timing of exercise, may be something to consider when working with type 1 diabetes. And usually better intensity to control for folks to be able to control their blood sugar is with a more moderate intensity, or to make sure you're very careful about progression to higher intensities. And if you are doing higher intensities, do it at a time where blood glucose can be monitored 4 hours out. So that's really most helpful. So now type 2 diabetes, again, this is one that used to be called adult onset diabetes, but now there's some kids, because of sedentary lifestyle and obesity, that may be getting type 2 diabetes. So insulin resistant is the term. So the body is making insulin, pancreas, beta cells may be making insulin, but the target tissue is not detecting it. So you have it, but it's like a rusty lock, and the key, you have it, but it's not going to work. And so at some point, this continues on, the insulin keeps on being, so you may have someone with type 2 diabetes that has high insulin and also has high blood sugar, high blood glucose. And that's typical for initial undiagnosed type 2 diabetes, where they have both, but still not being, the bottom line is that blood glucose is not getting into the target tissue. So there's insulin secretory deficits of the pancreatic beta cells eventually, because now it just gets worn out from having to make insulin and all the time, because blood sugar levels are high, and yet it's not being utilized. It is the most common form, so 90 to 95% of cases in the U.S. are actually the type 2 diabetes, which you could say is more positive in the sense that if we know that if individuals lose weight, if individuals become more active, diabetes can be much better controlled, and if it's in the pre-diabetes stage, they may never get to the type 2 diabetes. So it tends to be highly associated with those that have BMIs greater than 35. Folks that have a family history, the older you get, certainly, and being sedentary, it's going to increase your risk for getting type 2 diabetes, very similar to your increased risk for cardiovascular disease. So diabetes-related complications. Here's a little brief summary. Retinopathy is damage to the eye, the ball of the eye. And so when we look at exercise, we're going to think about that as well. So that's common. Certainly obesity is associated with those with diabetes. Kidney disease, and they are the highest risk group for amputations, lower limb amputations. They tend to suffer also from high blood pressure from over time. Having diabetes has caused damage to the arterial walls. Heart disease, stroke, so all that related again to the cardiovascular system. Liver damage as well. Really all the organs could be damaged because of the unbalanced amount of blood sugar. Neuropathy, we'll take a look at that. It's very painful for exercise with neuropathy. And nephropathy, which is the kidneys, damage to the kidneys, overall poor circulation. So exercise and physical activity benefits for those with diabetes. Well, I'm just going to put it all up here. Exercise, if you think about exercise, again, it's medicine. So as you take your insulin, you will also take your exercise every day, ideally around the same time. So you don't want to surprise individuals with diabetes as far as exercise intensity. They should know what exercise is going to be like. It helps them to control blood glucose much better. They eventually may require less insulin than those that are not exercising. It does, if they lose the body weight and improve their high blood pressure and dyslipidemia, they reduce the risk for cardiovascular events happening like heart attacks and strokes. And there's much evidence that for those that may be in the pre-diabetes stage, or that when it's combined with diet and comprehensive lifestyle modification, they could reduce the risk significantly of getting diabetes when they're older. Also, some good research for resistance training also has some positive effects on reducing the risk for type 2 diabetes, because for resistance exercise, the muscles utilize a lot of glucose, and so it's a great way to be, it's the best insulin-like type of exercise. And exercise seems to be superior, believe it or not, than pharmaceutical interventions, which is great. But because of the fact that exercise will use blood sugar, is important that we know what the risk could be. So if someone that is uncontrolled, individual that has diabetes that's uncontrolled, you could have exercise-induced hypoglycemia and exercise, that hypoglycemia that can lead into a coma, diabetic coma. So there is some risk that we need to be aware of. So the pre-activity screening is going to be significantly important for diabetes. If you think about our screening lecture, someone with diabetes, that's considered a metabolic disease. So right away, you know, right off the bat, that if they have a metabolic disease, after clearance, they can come and exercise. So ACSM screening, physician evaluation before exercise, for those that were previously inactive. So if they're sedentary and they tell you they have diabetes, they have to go check with their physician first. They're going to need medical clearance before being active. For those that are already active and they have no signs and symptoms, then they will only need the clearance for vigorous exercise. Like I said earlier, moderate exercise helps the best. If you're going to engage in vigorous exercise, you're going to have more spikes on the requirement depending on the intensity, and so you want to make sure that you get clearance for that every year. So some of the medical evaluations that may be included, glycemic control, any complications to watch out for, and the doctor or physician may do some stress cardiac testing of the individual. Those with diabetes at risk for heart disease, here's what you need to remember. They're older than 35, so meaning that they've had diabetes for a while. If they had type 2 diabetes, the longer they've had it, the more damage that could have happened to their system, so that's what you want to think about. Type 1 diabetes for more than 15 years. There is those folks that have always kept it well controlled, and so the risk is not as high, but those that have had times where they have not had it well controlled, that's when damage could have happened. And anybody that has diabetes already, not only they have diabetes, but they also had kidney disease, renal disease, right? So then you have metabolic and renal disease, and you could have someone that actually has all of that has cardiovascular disease, metabolic disease, and renal disease, and so then the precautions need to be take those more seriously. So looking at this pathway here, again, physical activity history is still first. Deciding yes or no is going to make a difference. Let's say they decide no. If they're sedentary and they have CMR disease, then you can look even whether they have signs and symptoms or not, medical clearance first for both. If they have CMR disease, right? So they still need to get medical clearance. So hopefully that was clear on what I said for both type 1 and type 2. Medical clearance is necessary first. If they're active and they've been active for a while, if they have CMR disease, we will have to stop for medical clearance if they're having signs and symptoms of indicative of a cardiovascular disease. If they're not having any signs and symptoms, we're going to need a clearance for vigorous exercise. And again, this is true for both type 1 and type 2 diabetes. So type 1 diabetes precautions. So it is all about checking for blood sugar. So here you see the way that it can be tested. They need to check before exercise, 30 minutes before and then 50 minutes after, because depending on their blood glucose results, that's what they have to do for food. So if their pre-exercise blood glucose is less than 100, they need to consume 15 to 30 grams of carbs for a session lasting 30 minutes or longer. So again, you can't surprise them. They need to know what to expect from the exercise routine, and don't surprise them. Oh, today we're doing a sprint workout while it sets. So they need to be prepared before. For those that get a reading between 90 to 150, they do not need to consume carbohydrates until blood glucose is below 150. And then for blood glucose levels between 250 and 350, exercise should only be performed if ketones are low. So that's another thing they could check, ketones, and then only at a light to moderate intensity. For blood glucose levels that are over 350, they should delay exercise when there's high ketones, or administer insulin if ketones are low, and then exercise at moderate intensity until blood glucose is less than 250. So this is information that physicians would advise them on. There could be some differences, and so your job is to figure out what these may be for this individual client. So the responses may be different. Ketones are checked in the urine, so this is something it wouldn't be a surprise to them. Something that you wouldn't do this test for them, they would do these tests on themselves. Type 2 diabetes precautions for exercise. So medical clearance is desired, especially if they have other things going on, and a medically supervised fitness test may be necessary. Blood glucose should be monitored regularly before and after exercise. If above 200 milligrams, exercise should be avoided until blood glucose is reduced. You can make an exception if urine ketone bodies are absent, but you're still going to just do light to moderate exercise if possible. It's possible. If below 100, then the client should consume 20 to 30 grams of carbohydrates followed by a glucose check. And be aware always with diabetes, make sure they drink lots of water, but be aware of possible dehydration. Other precautions for exercise. If client suffers from retinopathy, this is in the eye, you want to be careful with blood pressure increases, so that can be caused by vigorous exercise, but also resistance training exercise at higher intensities could also cause that. So more moderate intensity of exercise if they have retinopathy already. Clients that have autonomic neuropathy, kidney disease, peripheral artery disease, or peripheral neuropathy should be referred to a medical supervised program ideally. They need to work in a clinical environment. And again, be aware of other risk factors that they may have. If they already had a heart attack, if they already have renal disease, all those things. Other precautions during exercise. So now what to watch out for during exercise when you're working with a client with diabetes. They're going to be at increased risk for a cardiovascular event, so make sure you know your plans. They're at increased risk particularly for hypoglycemia. This could be your first aid event that could happen, that they could blood sugar levels could drop significantly, and then what happens is there's no glucose to the brain, so the central nervous system shuts down so that it can function at a lower amount of blood glucose, but that could be life-threatening. They're at increased risk for dehydration always, so make sure they're always drinking lots of water. Increased risk associated, remember, carbohydrates are loaded with water, so when you don't have carbohydrates in the cell, you're going to be at increased risk for dehydration. And so the body also tries to get rid of the extra sugar in the blood by peeing it out, remember that. And you're going to have an increased risk with high intensity resistance training, in particular if you have not gradually program them to work at those higher intensities. So be careful of your progressions, and make sure they note how they feel. So this would be a good instance of keeping exercise logs, and not just the exercises, but how they tolerated, how well they tolerated or didn't tolerate the exercise when it comes to the blood sugar levels. And be particularly careful how to take proper care of the feet. Make sure they have proper footwear. If they're going to be doing anything bare feet, make sure there's nothing they can hurt themselves on. If they're doing water aerobics, they should still wear water aerobic shoes. They actually have those, or some other form of protective footwear, so that they don't injure their extremities. Exercise helps certainly by helping to lower blood glucose levels quickly, improves the body's ability to use insulin, eventually can reduce how much insulin is required. It works like medicine works. It should be seen, exercise should be seen as you would medications. And overall, those that exercise regularly and lose weight and decrease their blood pressure reduce the risk of having heart disease. Other effects of exercise and insulin and blood glucose, it actually helps with the absorption of the insulin that they take exogenously, meaning like either the pump or the shots. Increases the ability of muscle to uptake glucose. So because of this, again, maybe they won't have to take as much, and helps the movement of glucose into the blood, especially working muscles are glucose sinks. Highest exercise risk is if it's blood sugar getting too low. So we worry the most about those drops in blood sugar. Maybe you've had it sometime, you didn't eat something before a workout, and 20 minutes in you just feel like, wow, your legs are lead. You can't move, you can't. And that's a little bit of what someone with diabetes going through hypoglycemia may feel like. But that's not going to stop for them. So it's very, very for them. Other special conditions to think about. Clients with organ damage that already, such as peripheral neuropathy, they're going to have an increased risk for ulceration and infection of the feet, because they just don't have the same sense of where they are. Their feet get numb at times, and so they're more likely to have issues with that. So we want to choose low impact types of activities. Make sure that, again, the shoes are great, they have good footwear, they're not too tight, and they support their body weight well. Watch out for dizziness or shortness of breath, and those with cardiac disease should seek medical evaluation. And here's a picture of what happens. Again, blood vessels with those with diabetes get damaged. So you see, this is nerves, and these blood vessels that are not getting enough blood supply, and they actually just shrivel, and because they're not getting blood, they're not getting oxygen, and so it's necrosis. There's death of tissue, of nerves, so they lose their sense of where they're at in space over time. Exercise-induced hypoglycemia, some things, and maybe you've heard this in first aid a little bit about hypoglycemia, but I want to talk about exercise-induced hypoglycemia. Is greatest risk when blood glucose levels are less than 65 milligrams per deciliter. Oops, sorry. Greater concern for type 1 always than type 2 individuals. And risk for hypoglycemia, again, as exercise intensity increases, when there's high intervals from low to high intensity, from rest to high intensity, the longer the duration of exercise, the more likely it is to occur. And not eating enough before, maybe taking more insulin, the dosage of insulin was too high, or they injected it into an exercising muscle. That's going to create problems for them. They should not do that. Some of the signs to watch out for, they just start to look weird. They may start sweating. They tell you that they feel like they're going to pass out, shaky. They can't focus or concentrate. Shaking or shivering are some common signs. Sweating, but not sweating like you would from exercise, has a different, they just don't look well. The heart can start beating very fast. They get anxious, and that happens. They in the worst, we don't want to get there, but the worst case scenario is that they lose consciousness. If they lose consciousness, that's a life-threatening event. You have to call 911. You have to get emergency personnel there as soon as possible, and then you would monitor for signs and symptoms to see if you need to start seeing. And here's some of that. Here, responding to a client with hypoglycemia, consider dialing 911 even if they're conscious. So think about that. They could go unconscious at any time. If you have an adult victim down unconscious, that's a 911 type of call. Immediate treatment with a carbohydrate will help. So that's usually you find that in your first aid kits, but other things to think about. You can, if they have, which they should. I wouldn't work with someone who doesn't have their blood glucose stuff with them. If they need to measure it, if it's below 70, they need to take 15 grams of a carbohydrate. If you know what that is, it's about 3 to 4 glucose tablets. Those sometimes come in the first aid kit. I used to have them, those, but then I figured out I could have just sugar packets. So sugar packets also work. You can have like 3 sugar packets. It's the equivalent. And those are easier to find than the glucose tablets. You can have those. And just so happens that at the YMCA where I'm at, they still have coffee service, so there's always sugar packets. But you can keep them in your gym bag, or you can keep them available if you're going to be working with someone with diabetes. Also, half a cup of Coke, like a regular soft drink, not diet soft drink, obviously wouldn't work, or juice. It's tough with the crackers when they're not feeling so great because you got to chew it, so something faster. Like sugar, they can put a packet in their mouth and it just kind of melts in their mouth. That works very well. Would be my suggestion. And then they have to check again. So they wait 15 minutes, and then they have to remeasure glucose levels. And usually this works very quickly. They immediately start to feel better. And again, you want to try to be aware that they could go unconscious at any time. So you have to determine whether you feel like that you're going to lose them and you should call 911, or whether you can go ahead and test them. Or again, this is something that they would do themselves, not you. So when do they cannot exercise at that time? So I'm saying here, not indicated that they exercise for that workout session. If glucose levels are greater than 250 and there's ketones in the urine and they're type 1, they need to weigh it out. If blood glucose is greater than 300 without the ketones for type 1, they should wait it out. Clients with type 2 may participate in exercise provided they're feeling well and they're well hydrated. Those that have proliferative retinopathy, they should avoid strenuous high intensity activities, so you have to be careful about that. And those with severe kidney disease as well. And then loss of protective sensation in the feet. So if their feet go numb at any time, that's a high risk for fall, especially if you're working with an older adult. Be careful with anything outdoor, like walking or jogging. Swimming or biking could be good indoors as an alternative. Or anybody, this is true for anyone, but certainly those with diabetes, if they have an acute illness or infection or fever, they should delay exercise. If they have an underlying cardiovascular disease that has not been medically evaluated, so they're complaining again of chest pain or anything like that, they should be seen before continuing on. So this is going back to your decision tree for the ACSM. So here are the general exercise guidelines for clients with type 1 diabetes. Again, think of exercise as medicine. So aerobic exercise, start with large muscle groups, things like walking, jogging, biking, swimming, stair stepping, and look at the frequency. The goal is to do it every day, like medicine for aerobic exercise. Moderate intensity, at least initially. If you're going to go more vigorous, again, do it very gradually, as tolerated. Make sure they're keeping logs of how they feel, what their sugar responses, what blood sugar responses are. And that will make sure that you don't have a hypoglycemic event happen. And so here are the other recommendations as far as um, resistance training, flexibility training, and balance training for individuals with type 1 diabetes. Also, again, that neuropathy, peripheral neuropathy, for some it feels like they're walking on needles. So sometimes that stops them from, they're doing it and then they have to stop and rest a bit and then they can continue on again and keep doing it. So you have to maybe work on how long you're going to have your duration and increase as tolerated. So here's for type 2 diabetes. Again, different frequency, ideally to get it to 5 to 7 days a week. Start at moderate intensity, gradually move your way up to higher intensity. You can do the same as you would with obesity, 10-minute sessions, and then move to longer minute sessions. And here's different calorie goals as well, which is helpful, which is very similar to what we saw with obesity. As far as the recommendations, and resistance training also could be very helpful. Okay. Here's a summary of the resistance training guidelines. It's safe. Do be careful for those with retinopathy that you don't have too high of an intensity because it can lead to damage to the retina, to the eye. Again, just to remind you again, watch out for hypoglycemia, can occur during and after exercise. Hyperglycemia, meaning blood sugar levels do not drop, can occur in type 1 diabetics with poor blood glucose control. Those with neuropathy of legs and feet might have gait or balance problems, so be careful with quick changes and maybe be aware of that, and maybe have, for aerobic exercise, may have to use a treadmill or a bicycle or something like that, or the pool. And ideally participate in activity same time each day, like you would take a pill within an hour or so. So same time each day was most helpful. And those with diabetic ketoacidosis that have hyperglycemia and high ketones when the body it's hyperglycemia and high ketones when the body is burning fats instead of carbs due to lack of insulin. So it's more type 1 diabetes when it's not well controlled. So other things to think about, again, because of hydration being a problem, make sure they drink water before, during, and after exercise. Encourage them to drink when they're with you doing exercise. If they're going to be exercising without you, remind them to not do it alone, because if something were to happen as far as hypoglycemia, they're going to be maybe unattended for a very long time. They could go into a diabetic coma, and then that's a life-threatening condition for them. Use perceived exertion to monitor intensity. We want that moderate intensity, about 13, 14. Shoes, again, to remind you, and they may want to consider wearing a medical ID bracelet for identification if they do have any of that happen. So that lastly brings me back to your case study. So I'll put it up here. Again, remember Carrie. Think about what you would do with her now that you have more information. How do you proceed with her? How does her blood sugar level? What would you do? Hopefully you now have some answers with that.